Good evening, Fresno. Welcome to our second Fresno County Mental Health Services Act, otherwise known as MHSA 3-year planning feedback session. So my name is Ahmad Brahmi. I'm a division manager here at the Fresno County Department of Behavioral Health, and I'll be going through our feedback session this evening. A little bit about our follow-up sessions. We're going to be going through what are some of the things that we heard during our community planning process. We're going to discuss a little bit about how COVID has had an impact on some of our Mental Health Service Act planning efforts. What are some of the next steps, and what are some things that you can look forward to? One of the things that wanted to make sure that we reiterate as we go through this process this evening is that the feedback sessions are actually not our public hearing or the 30-day public comment that is required as part of our Mental Health Service Act planning process. But really, this was something that we had committed to doing when we started the community planning process about a year ago, last November and December, because we wanted to make sure that we were able to come back to our community partners and providers and stakeholders and report back on what we heard, what we were doing before we put the plan forth for people to provide public comment. A lot of times our community would share, has in the past shared ideas or concepts, and those things did not always appear in the plans. And so people sometimes may feel that they weren't heard, or their ideas were not validated, or were just not good ideas. And so what we wanted to do was commit to having these conversations to let our community know what we heard and why some things may or may not appear in the plans. So that there's not just only transparency, but we really can have that dialogue to make sure that we're all on the same page in terms of what we're doing with the Mental Health Services Act, otherwise known as MHSA. So, what we heard. Last November and December, we began our MHSA, actually in October, we began our MHSA 3-year planning process. Part of that MHSA planning process, or the community planning process, which we call CCP for short, we conducted 21 in-person forums. These were different days, different times, different audiences. We did them in rural areas. We did them on weekends, different, as many forums as we possibly could handle in that 2-month period to ensure that we provided as much opportunity for input. These were all in person. Like I said, we did do 2 virtuals. Those virtuals we did were long before COVID and long before we became really proficient at doing virtual and streaming opportunities. In addition to the forums, we received over 700 surveys that were used to drive that process. We conducted 21 key informant interviews. Those key informant interviews had some members of our behavioral health system in there in terms of some advocates. But largely the key informant interviews were for folks outside of our behavioral health care system so that they could provide a different perspective in terms of what are needed in the community. So they were some more community leaders, elected officials, and just some of our other sector partners. And then we also participated in several feedback sessions or community sessions that were not directly related to our process, but we sat in those processes, meetings, things of that sort in order to get some additional feedback, and then been able to also incorporate and take some information that we have found from things like our full service partnership evaluation and some other efforts to, again, get as much input as far as what our community is saying, looking for, and needs to try to incorporate into this. Through that community planning process, we found 14 different themes emerged. Those themes are on your screen. One of the things that we want to note is when we were doing the community planning process, we did not list all of the services and programs that are MHSA funded or that were in the plans that would have really changed the dynamics of those groups. It would have been us talking to the audience really versus us hearing from the audience. So any ideas that came up, we put in there. So some of the things that emerged in these themes were actually programs or services that were in existence or programs and services that were being worked on at the time. So I'll go through a couple of these and try to lump them together and address some. So item 1 is a potential theme or area that came up that we may have some issues in fully addressing, which is increasing providers, and that has to do with more the impact of COVID having on our budget, which I will discuss in depth coming up here. But at the same time, we have the opportunity through some additional new WET funding, which stands for Workforce Education and Training, that will allow us to potentially help grow our workforce, which is an area that we definitely need, including peers, and including peers in more of our programs and services in our program designs. Items 2 and 4, which you had saw previously, stigma reduction, education and training for targeted groups, and then support for persons experiencing, well, I'm sorry, that's not number 4, education and support for families, and then education and training for targeted groups. Those are all things that are already in place or being developed or occurring through ongoing efforts, either through our stigma reduction campaigns, our outreach and education campaigns. So those are themes that came up. So we're not going to necessarily do those as separate programs, but those are ongoing things that we'll continue to try to facilitate and continue to move forward during the next 3-year plan. Item 5, for example, support for persons experiencing homelessness. We have some programs that currently work around that, some housing efforts, No Place Like Home. So there, as well as an innovation plan that was approved last year, the Lodge, to look at some of those populations. So there may not be a specific new program in this MHSA 3-year plan, and that's because we do have some other efforts that are already doing that, and or that we may redesign or try to support with and leverage to address those needs. Wellness centers and activities, that was a theme that was there. We do have our wellness centers, Blue Sky, which is one of our peer-led wellness centers. We have the youth empowerment centers. We also have a new project through a separate funding source that we're doing with the Fresno County Superintendent of Schools, which are going to be 4 regional wellness centers that will be established that can house and support a lot of other services. So again, there's things that we heard that came up as themes, but they're not going to be specific action items for us through the Mental Health Service Act funding, because they're either in existence or we're able to leverage some other opportunities for those. Item 7 is being addressed through one of our innovation plans, as well as working on efforts outside of just MHSA. So trying to improve transportation does not automatically mean funding transportation programs, but we do have one experimental project or research project that we're piloting, like I said, through innovation. Some of it may work with the transportation providers and the FACTS and rural transits to see how we can improve those routes and times. Through the impact of COVID-19, we've resorted to utilizing a lot more telehealth, and as have a lot of our providers, and finding that is another way that we can sometimes remedy and or limit the impacts of transportation by allowing individuals to access care through their phone, remotely, things like that. But we're also going to continue to look at transportation. It just may not necessarily be an MHSA specific project to address those. We've added peers to almost all of our new innovation programs. So last year we had 3 plans approved. We're working on several more, which I'll come to here in the near future, that we'll be looking at including and utilizing peers. We also have the opportunities with the passage of Senate Bill 803, which was signed into law this past September, that will increase opportunities for persons with lived experience as peers, peer support, to be more involved in our system, and also to be able to fund potentially those positions through the work that they will now be able to get reimbursed for through things like Medi-Cal. One of the other items we have on here, I think is theme 10, was assisted outpatient treatment, or AOT. AOT is something that we're going to be reviewing. There are some new legislative requirements for counties to offer assisted outpatient treatment, or AOT. We're looking at whether MHSA would be a funding source for those activities, if that's something that is viable that we can do as a program. But it's not going to be something that we're going to necessarily be calling out in this MHSA 3-year plan, which I'll discuss more around financial considerations. So it doesn't mean that the county may not do those. It just may not be specifically in our MHSA plan, and we may look at some other resources and resources and opportunities to bring such programs into existence. There was a discussions and some of the themes that came up around inclusion of individuals that are justice involved or better serving justice individuals. And just wanted to note again, during those community planning sessions and listening sessions, we didn't cross those out or note that we do have full service partnership programs as well as other MHSA funded programs that are geared towards specifically justice involved individuals, several of our collaborative court programs that are MHSA funded. So those appear on our themes, but they may not be something that is going to be addressed in terms of new programming in our 3-year plan because they're already existing. There will be one potential program that I will touch on in a little bit that will be justice involved, so it'll add to the justice involved. But for the most part, we do have a number of justice involved population programs that are funded through MHSA, so we're not going to be adding or expanding those at this time. Well, there we go. So really, you've heard me say a couple of times as far as the impact of COVID-19 and COVID-19 has been here with us for a large part of this year. A couple of things to remember is that we were set to complete our MHSA 3-year plan. Our goal was to complete it in the spring of last year, have it go through the public hearing process, have these feedback sessions, which we're doing this evening, have several of those in the spring, have the plan done, approved, and submitted to the state before the end of the fiscal year so that the plan would be effective for this 3 years. COVID-19 occurred right around the times when we were planning to do those, shelter in place, really changed our priorities, our abilities and capacities as we shifted priorities, and also we're looking at supporting broader countywide efforts to make sure people were still able to receive services, addressing the need to shift to largely telehealth care, looking for safety of staff. So it did change some of our focus at the time, and so when we did pick up the 3-year planning process, it was not going to be feasible for us to finish it before June 30th. Additionally, that shelter-in-place order and closure of a lot of businesses had a significant impact on California's economy. And as a reminder, MHSA, or Mental Health Services Act, is actually funded through a 1% annual tax on incomes over $1 million. So with the California economy having a significantly downturn, that correlated with our MHSA funding significantly being reduced over the next several years. And so we wanted to also look at what was that impact going to look like, what would our revenues be before we decided to add programs, to try to expand programs, and really look at what we would be able to do in light of that fiscal impact and looking at what we could do to sustain programs. So that caused a delay. We did file an extension and were approved by the state to complete our MHSA 3-year plan, which we're hoping to do here very soon. The only funding that we really do have, two sources of funding that we did have available in this year that would allow for some new services are WET funding, workforce education and training, and in that part, statewide, there was opportunities for WET grants. Counties were required to put up a match, and as a result, they would get that match back plus some additional funding. So in the case of Fresno County, it was Fresno County putting up approximately $300,000, which would then allow us to draw a total, counting that money back and some additional funds, about $900,000 for the next 3 to 5 years to be able to do some workforce education and training, which I'll go into some of the activities we're looking at doing with those. Those are going to be career pathways, scholarship programs, loan repayments as a way to really diversify and also grow our workforce. That again was like a separate funding category that became available. The other funding category that we have money that allows us to do new pilots would be around innovation, and innovation funds have to be utilized for innovation. There was some discussion this summer in light of COVID and some of the reduction in our revenues for all the counties, could we utilize future innovation funding to support some of our other programs until the economy changed or until our revenues got back to previous levels. And that was something that was not approved by DHCS and the legislature. So our innovation funds are still set aside specifically to do innovation, and innovation funds are funds that if we do not expend them or at least have them allocated and encumbered in state-approved projects, could be reverted back at the end of that term. So in this particular case, we have some money this year that if it's not approved as in new innovation plannings would revert back to the state June 30th. So those are really going to be the new services that you're going to see are going to be things that are driven by some wet dollars and some projects that are going to be driven by innovation. Some of the things to remember with innovation, which I'll dive into, is these are one-time funds. They're funds that have really specific parameters in how they're used and applied. The things that we're trying to do to mitigate or lessen the impact of COVID-19 at this time is really looking at where are opportunities for us to increase billing. Are we able to access other funding sources and revenues so that we're not relying solely on Mental Health Service Act dollars, or where we could bring in some additional revenues, because through the Medi-Cal billing is really the only source where you can get additional revenues. Everything else is is based on income taxes and tax base, and with the current economic downturn, those revenues are actually going down, not up. We're looking at what are programs that we may need to freeze, and by that I mean programs that were in our MHSA 3-year plan that have not come to fruition yet or have not been enacted yet, that we would continue to keep in the plan but not start until such time that we have the funding available to not only start them but be able to sustain them. We don't want to start a program for a year or two and then have to stop the program. So there's programs that we've left in the plan, and you'll see those from previous plans, but they have not been enacted yet and may not be enacted until such time that we have funding. But leaving them in a plan makes it easier for us to be able to implement them when we are capable and ready, versus having to go through a whole new process to add them back in. Freezing funding levels, so that is something that we've been discussing for the past year with our current providers. We will not be increasing contract amounts over the next 3 years, but we will keep them at their current levels. And that's just really more so that we can continue to sustain programs, not have to eliminate programs, and at this point not have to reduce services. We will be sunsetting some programs. Right now there are some programs that are identified, you will see in the plan, that are specifically called out that we are recommending for sunsetting or retirement at the end of this current fiscal year. And fiscal year, for people that may not be familiar, runs from July 1st of the year to June 30th. So the fiscal year that I'm referencing to right now that will be ending will actually be June 30th of 2021, not December 31st. And there's some programs that we're looking at potentially having retire and or sunset, and those are either programs that have been underutilized, not utilized, programs that don't really align with the funding requirements, and or are not we have not been able to demonstrate outcomes for. And then last one is right sizing of programs, which is really adjusting program budgets to more closely align with what they're actually expending. So if a program is costing, has a budget for a contract for $100,000, but they're only spending $50,000, by then changing and adapting the budget to $50,000, $60,000 allows that program to continue, but frees up some additional funds that may be tied up to a program that's not being utilized and used elsewhere. So what you can expect. So what we're trying to do is, in this new 3-year plan, is provide basically the guidelines and direction for how we're going to use our Mental Health Services Act funding to continue programs, to close the gaps in our service system, and also to be transformational. This plan is going to see more like the annual updates, in that there's not a lot of new programs, there's not a lot of changes, and primarily those, as I noted, were because of impact that COVID-19 is having on our budget and our specifically Mental Health Services Act revenues. So we're continuing to move forward, but with the exception of WET and innovation, there'll be limited growth in these programs. Most programs are not expanding, we're not adding, like I said, new services. We're looking at freezing some of the ones that are in there, and potentially we're recommending sunsetting some current programs. But as we finish a independent third-party evaluation of right now all of 10 of our PEI programs. We may make some additional changes in terms of merging programs, blending programs, leveraging other programs, and like I said, also potentially sunsetting some programs. But these will not be limited to PEI. That's just the current effort right now is going on is for PEI. It is our intent as soon as this plan is over to go through and do a careful evaluation and assessment of every one of our MHSA funded programs to look at where are opportunities, as I mentioned earlier, to where we could leverage other revenues, areas that we could be drawing down additional Medi-Cal dollars, areas where we could maybe combine programs to make better use of those. It could be things like that to program designs. Are we duplicating programs? So we're going to be looking at how we can really leverage our opportunities with those plans. So you're not going to see a lot of new, like I said, with the exception of innovation and WET. Do want to emphasize a point as well that we are doing our best to try to have plans be focused on processing and continue to have community input, looking at how we can approach services from a health equity lens, being more data informed, data driven. So really looking at our outcomes. Do we have programs that make sense financially, cost per person? Do we have programs that are leveraging all the funding that's available out there? Are there programs that could be utilizing other funding? Making sure that the programs are sustainable, making sure that the programs match with the overall strategy that the department's trying to set forth, so we don't have programs that are kind of scattered to address the need, but do those programs really help us develop an overarching system of care, and utilizing MHSA and these programs to, like I said, close those service gaps, to be transformational, to address health inequities, and really help have a whole person, holistic system of care that addresses broad range of needs in an organized manner versus really scattered and fragmented. We do want to emphasize that MHSA funded services are not grants. We had discussed in our community planning process the possibility of creating what would have been mini grant programs, allowing CBOs and community organizations to maybe access some MHSA dollars to develop capacity, develop some specific programs. In light of the significant impact that COVID-19 has had financially on our MHSA revenues, being that we're in the red right now and working to get back into the black, it would not be prudent to add again programs and services as we had initially discussed and had received some feedback on. So MHSA funds are programs at this point are not grants, they are contracts. They should be based on the actual cost to perform the service. So those are, again, things that we're also looking at of making sure that our providers or contractor providers are not spending the full contract amount because they may have had that experience or requirement with grants, spending it or losing it, but really make sure that they're spending money to the cost, and where the program are not utilizing that entire dollar amount. It's not a matter of use it or lose it, but that allows us to shift those funds to maybe help sustain other programs. So it really goes for the greater community good versus a sense of having to spend the money or else they would lose it. Let me see. I'm trying to make sure that I stay consistent with our feedback session that we did on Tuesday, because our intent is to, again, just provide multiple opportunities for people to get the same information. So I am trying to make sure that we remain fairly consistent in not just the topics that you see on the slides, but in any of the talking points that I'm doing. So if you see me glancing at my notes, it's to make sure that we're trying to be as true and consistent of that. So regardless of which session people listen to, they would be getting pretty much the same information consistently. So then the new slide that you see behind me, or that's now on your screen, key new items. Wanted to note that the new efforts are really, as I mentioned, around WET and around innovation. But I do want to call out just some things to be aware of with innovation. Innovation fundings are specific fundings that are set aside. Innovation projects are for 3 to 5 years. Whether you do 3 years or 5 years, you don't get additional funding. It's how you're going to take that allotted dollar amount and stretch it out either for a program that lasts 3 years or 5 years. MHSA funding or innovation funding is one time. So once the project is complete, or the research or the learning or the pilot, and the program is deemed to be something viable or something that is desired, counties would have to find other funding to maintain those. So one of the things we're trying to do is make sure that we don't use innovation to start new programs that we're not going to be able to sustain. And so a lot of the work that Fresno County has been doing and will continue to do with innovation programs is really to pilot, to thoroughly evaluate, look at models, look at practices, look at opportunities that allows us to either understand if something is going to work, and if not, not to continue funded. If it does work, to then be able to find other funding revenues for it. So innovation plans are definitely great opportunity to pilot, learn, and test, but they're not really ideal if you're utilizing them for seed money or for startups, because you do have to, within 3 years, come up with additional funding, ways of funding those projects and programs. There's 3 programs that you see on your screen that we're going to be addressing here in a moment around innovation. 2 of these 3 projects we've put together in some concept papers, which I'll tell you where you can review those shortly. I don't believe they're posted yet, but we will post them as soon as these feedback sessions are done. We do have innovation projects that we're looking to get approved before June 30th, 2021, because there are some innovation funds that would revert if we do not get plans approved. So we're working diligently on those. Of the 3 plans that were innovation plans that we're looking to present and move forward this year, which will be in this plan, 2 of the 3 are actually existing projects in our past MHSA 3-year plans. The Suicide Follow-Up Call Program was introduced in last year's annual update as a potential PEI program. For a variety of reasons, it had not been moved forward. So it is a project that we would like to move forward, and we could move forward with it as an innovation, versus having it remain as one of those freeze programs in our PEI program. Based on the increased call volume our local suicide prevention lifeline has been receiving, based on our efforts to reduce and curtail suicides, based on a lot more crisis calls and suicide risk factors during COVID, it was not a program that we really wanted to have linger for the next couple of years, and we wanted to look at a way to move forward. And so thus we're making a recommendation for it to move forward as an innovation plan. It's in our plan, but moving it forward as an innovation project. And what we're looking to do with it in terms of being innovation is not doing the follow-up call program itself, because that has been proven as a very effective, cost-effective, and also effective model to engage individuals after a suicide attempt or suicide risk, and getting them engaged and connected to services. But what we're trying to do with the innovation piece is having that follow-up call program also collect information from the individuals who may have been in crisis, experienced some suicidal ideation or post-crisis, to find out what were some factors or things that may have been occurring in their life with them leading up to that moment, and being able to identify if those seem to be some social factors, community factors, especially amongst our youth, that we could then respond with some specific targeted prevention, outreach, and response and coordination, versus a lot of times that information is not available readily or timely, and so maybe months later before we're able to identify what may have been some factors that have contributed to that, or may have been things that could have resulted or caused a contagion or a cluster. And so with this program, we think innovatively we could get some real-time data to be able to respond to possible suicide risk contagions, suicide factors, and thus reduce suicides. There'll be more explanations in that suicide prevention follow-up call plan. As I said, it will be posted on that website, FresnoMHSA.com. We have not posted all of those because we're trying to complete the feedback sessions, but those will be posted so that you can view them. Those will be submitted. Those have been submitted to the OAC as concept papers to see if they're viable ideas. If they are, then we'll come back and have additional planning, discussion, 30-day public comment, and go through the process, and then eventually get them submitted to the Mental Health Services Act Oversight and Accountability Commission, which I will call the OAC for short, to be able to approve and allow us to move forward, and also encumber the funds for those projects. The second one is the Justice Multi-Agency Access Point Program, or Justice MAP, which emerged in one of the previous annual updates. It's again a project that has been in our MHSA 3-year plan. About a year ago, there was an effort to see if that plan could get moved and implemented before the end of the last fiscal year. Based on the work that goes into innovation plans, but also the process to get innovation plans approved, it was not likely that that would be a project that could have gotten done and implemented by the end of the last fiscal year. So that would have been June 30th, 2020. And so what we recommended was for that project to potentially be moved to a PEI category where it could be moved along a lot faster, a lot quicker. That effort came to a halt when we experienced the closures and the impact of COVID for a number of reasons. Courts were closed; they were not meeting folks in person. We also, as a PEI project, were then facing limited funding and looking at could a program be started and then sustained. It just wasn't going to be viable, and so the program was put back on the shelf. Looking at what our potential budgets would look like in this upcoming 3 years and looking at what we had available as innovation funding, the idea reemerged of moving it back and moving it back into innovation and moving it forward as an innovation project. What we're looking to do differently with this Justice Map than our current map, which is the multi-access agency, for a number of reasons, program, is to look at how we can modify the map tool that could be more specific for justice-involved individuals, that could look at specific whole person needs, that could look at a screening and linkage tool that is also culturally competent, addressing specific, like I said, justice-involved needs, and looking at how that would look like. But what this plan is going to be is more of a plan to plan. It was really going to be difficult to develop a justice map program without having a lot of community discussion, without having a lot of sectors involved, without doing a lot of planning and looking at logistics and technology and things like that. So we're proposing a plan to the Mental Health Services Oversight and Accountability Commission that would be a Justice Map program conducted in 2 phases. Once approved, we would spend a year working with a lot of our partners, including individuals who have previously been involved with the justice system, as well as individuals who are currently involved with the justice system, as well as our criminal justice partners and our CBOs and our health partners and our housing partners and all the other partners, to really see what would a program look like that could assist individuals who are justice involved in getting the services that they need in a way that would be timely and would help them either minimize their involvement or length of involvement with criminal justice systems and or exit the criminal justice system quicker. So those are the things that we're looking at doing innovatively. So phase 1 would be a year of planning and a lot of development and design, and then going back to the OAC for approval of a phase 2 that would allow us to then implement the program for additional 2 years and really doing a robust evaluation to see what parts of the program were most effective. Was it the model itself? Is it the potential screening tool? Is it the involvement of peers? Is it the collaboration across sectors? Was it the design itself? So those are all things that we consider to be innovative that have not been done, and that is how we're looking to present the Justice Map program. And then lastly, it's the California Reducing Disparities Project Evolutions. That was one of the concepts that was going to be in this new innovation, in our new MHSA 3-year plan, as an area for us to explore. But until recently, it was not something that we thought we were going to do until we again looked at our possibilities with innovation funding and thought that this could be a way of supporting these programs. So real quickly, the California Reducing Disparities Project Phase 2 was a state MHSA funded project to look at community-defined programs that were not evidence-based but specific to various cultural and population groups to look at could non-traditional approaches be effective. Again, these were state-funded MHSA, not counties, so most of these programs are through vendors that work outside of the county with these programs. They do not report to the county, but the funding for these programs, pilot programs, is set to sunset at the end of this fiscal year. And in Fresno County, we have 3 great programs with 3 local vendors. One that's provided by ICIS, one is provided by the West Fresno Family Resource Center, and another one by the Fresno Center that are population specific, looking at African American youth, older Hmong adults, and younger Latino populations. These projects would sunset, and there's, with the downturn in the economy and the limited funding availability, those would not be programs that Fresno County would be able to support or sustain. However, as possible innovation programs, they are programs that we could continue and also work to adapt. So what we're proposing with these California Reducing Disparities Projects evolutions is not to fund the programs as they are, but to continue funding them and then working with their populations, working with the cohorts and participants in those programs, as well as the providers, to identify what may be things that we can modify or tweak in their programs without them losing what made them community defined and really what made them successful, making some minor tweaks that would allow them to be in the future more easily and readily funded through MHSA or other funding sources. So bringing kind of the non-traditional approach into aligning a little bit better with what would be more of the standard behavioral health system, but again, not losing what has really made it creative and innovative. So we have worked with all 3 of those providers about potentially putting this project forward. We have had some discussions with the MHAOC, and so we have submitted a concept paper for that, seeing if the idea is viable at all. If the idea is viable, then we'll definitely be coming back and writing a formal innovation plan around that will have a number of community forums, probably virtual at this point, as well as 30-day public comment and a lot of discussion around those. So really, out of the 3 innovation programs, 2 were actually, one was a previous innovation program that we just had not been able to move forward. The second was a PEI program that we're a prevention early intervention program that we're looking to move forward as an innovation based on a lot of the needs that we've been experiencing amid COVID-19 and suicide prevention, but also because of the need to really see if modifying this program will be effective. And then the third one, which is the one that is new, is the California Reducing Disparities Project. But these were really opportunities that we thought as a community we could jump on to not only support, but look at how we can better bring them into our system of care to address some really specific underserved or inappropriately served communities and populations with some culturally specific, culturally responsive programs. I'm trying to look and see if there's anything else that we left out. And if you watch the one we did Tuesday to the one today, this part is not going to be identical. It's not going to be verbatim. So I'm putting that qualifying statement out there. What we are working on right now, finishing, is the Justice Map concept paper. So we've gone through some revisions. We hope to have that done as soon as possible. So hopefully by next week, we're pretty close to having a draft of that done in the concept paper that we hope to submit to the OAC, but also we will post all 3 of those to our website. If you go to www.fresnomhsa.com, you'll be able to find those probably start of next week. The reason we're working rapidly to get these submitted is that there's a number of counties, probably half of California's counties, that have innovation funding that is set to revert at the end of this year. And so we know there's going to be a rush to get plans in there. So the sooner we're able to get our innovation ideas and concept papers to the Mental Health Services Oversight and Accountability Commission, sooner we can see if those are viable ideas, sooner we can start the process, sooner we can write the plans, get them submitted, and have us have a commission date saved so that we can ensure that at least 2 or 3, if not all 3 of these projects are approved before the end of the year, to ensure not only we avoid reversion, but a couple of these programs really need to get started. So the CRDP is a project that their funding would sunset at the end of this year, so we want to get that in place and be able to continue those programs so there's not a break in there. The suicide prevention follow-up call program, again, that's a challenge and issue we're having right now with increased suicide ideation and crisis that we want to make sure that we address. And the Justice Map being planning in the first year, but it would be really worthwhile to start getting a lot of that planning going on, so that could be a program that could come forward. So that's why there's a little more expediency and urgency in our efforts around these innovation plans. Again, like I said, is so that we can save our space in the queue within the commission, so that we can get those projects approved by the state the state being the Mental Health Services Oversight and Accountability Commission, and be able to move forward. So the ideas are in the 3-year plan, but they will be required to have their own individual plans in addition to the 3-year plan. And so that's why what you're receiving is just information in terms of concept papers, because that's usually all we put in there. Each of these innovation plans could be between 30 to 50 pages. Those of you who have read our MHSA 3-year plans do not want us to add another 3 plans of 50 pages or an additional 150 pages for your leisurely reading. So that's why we're fortunate that they will be submitted as separate individual plans, but we plan on doing that as part of the overall MHSA 3-year plan. I think I'm going a little longer this time, Brian, than last time. So those of you listening in this time, I apologize, but I just want to make sure that we are thorough and making sure that we do provide everyone with full input and understanding of what we're doing with our MHSA 3-year plan. So some next steps, these will be pretty simple and brief. We hope to get the overall MHSA 3-year plan done here as soon as possible and posted. We wanted to make sure that we gave you a heads up as far as what might be some things that you see new in there, what will be some things changed. As far as programs that are slated to sunset, those are called out specifically in there. It is a large plan. I'm going to warn you, it's a combination of our new 3-year plan as well as last year's annual update. The new 3-year plan is about 100 and... No. It's more than that. It's about 140, 150 pages. That's not counting the annual update. The annual update will probably be another 20 to 30 pages of content, and then specific program descriptions and sheets, and with about 70 different MHSA programs, so that's about 70 pages there. But what we are going to try to do this time around, as opposed to where we were not able to do our annual update, is to provide a table of contents and see if there's a way for us to tab those out. So if someone wants to review specific sections, they can go to and identify those areas that they want to review. We are going to complete these follow-up sessions. We have one more left, which will be tomorrow in Spanish, and that one is, I believe, at noon, or no, it's towards the end of the day. Towards the end of the day. And then we'll have done 4, so we'll have done 2 in English, we will have done 1 in Hmong, and then 1 in Spanish. These will all be available on both YouTube as well as on Facebook, so people can go view them. We hope to have the plans posted within a week or so. So after these, those plans will then be posted for 30 days. At the end of the 30-day period, we will have public hearings. What we are going to try to do is have a couple of public hearings, and by having a couple, we want to make sure that we have a public hearing that is in Spanish, in Hmong, as well as English, to just allow for better participation for our communities. And then after that, we will be, if the public hearing is not run concurrently with our local Behavioral Health Advisory Board meeting, we will then take those to our Behavioral Health Advisory Board, but we hope to be able to coordinate with our Behavioral Health Advisory Board to maybe do 2 at the same time, so have their board hearing as well as the public hearing, so that then the board can vote to approve, and we will then submit it to our County Board of Supervisors for approval, and at which point the plan for the most part at that point is ratified, and we will submit it to both the OAC and the DHCS so they have it on record. But having the plan approved gives us spending authority, gives us the ability to go forward with any projects in there, including those innovation plans. I think I covered those in there. So between now and when these plans are posted, and as well as after they're posted for the 30 days, you can reach out to us with feedback, with comments, with questions. This next slide will provide some of the info on there. You can email us at mhsa@fresnocountyca.gov. You can submit questions, comments to that email address, and we will do the best to answer your questions, provide any additional insights. Once the plan is posted for your review, and like I said, it's pretty much done. It's now doing a lot of formatting and editing in there, making sure all the numbers are filled in, making sure all the links work, and really the big part, trying to develop a table of contents and tabs to make it easier for people to go through. Once that is available, people will also at that point be able to submit not just emails and feedback, but we'll also have public comment cards that they can also submit, and we'll make sure to post information on when that is going to be, when we'll have those public hearings, those things both on our website, which you'll be able to find if you go to www.fresnomhsa.com, and you'll see that appear on your screen. That'll take you directly to our MHSA page on the county website, but it'll be easier to navigate by just using that URL or that web address, and it brings you to the page versus having to go through the Fresno County website and get to the DBH page and then go find the MHSA page and try to find the plans. So if you use just the www.fresnomhsa.com, it'll take you to there. We hope to be able to post information on when the plan will be released. When the plan is released, it'll be available for viewing up there. We'll also put when the public hearings will be for the 30-day public comment. The public comment cards will be on there as well. So people can fill those out and submit those if they want, or they can just email us again at mhsa@fresnocountyca.gov, with any questions. So you can do those now or once you get a chance to review the plans. I'm trying to see if we have, I know there's a delay between us speaking and what is actually showing up on your feed. So if you have questions or anything that you would like for us to maybe try to answer, if we're able to answer this evening, you can go ahead and type your comments into either the Facebook stream or into the YouTube stream, and we will see if those are things that we can address today. If you watch this later or go back and watch it later and something comes to mind or you have a question, by all means, please email us. We'll be able to either answer it or do the best we can to answer, but we will make sure to provide you with a response. And like I said, we hope in the next week or so to have not just those innovation plans posted, but also the new MHSA 3-year plan posted and available for your review so that we can complete this process that we have now been working on for about a year. If people have questions on even what an acronym may have been or something like that that we failed to cover, feel free to put those in the chat as well, and we'll try to answer that.
Not seeing any comments.
Yeah, it doesn't seem like we're having any yet, but we'll give it a few more seconds. Brian and I want to thank Brian Bishop from our team, who's assisting us with this live stream and providing some feedback and staying late this evening. We'll stay a few more minutes just to make sure that we're not missing any delay, but we're not going to stay too late. We'll give it another minute, Brian.
Yeah.
You think? Yeah, let's do one more. I know also Erin's tracking that also remotely the feeds, and she's reporting that she's not seeing any comments or questions yet either. So we'll just give it a minute because of the delay, and if not, we'll end it here. All right, well, it doesn't look like we're receiving any questions or comments yet, which is fine. If someone comes up with a question or comment later, by all means, again, please email us, mhsa@fresnocountyca.gov. Go to the website, www.fresnomhsa.com. You'll be able to find information on upcoming dates. Once we post it for public hearings, there'll be an opportunity for you to still provide questions, comments leading up to us posting the 3-year plan, as well as the 30 days during that posting. So these feedback sessions were really a chance for us to give you a chance to have a better understanding of what we did, to try to make sure that we have some transparency with our process, but not forcing people to have their questions or be able to really get understanding on what's going on once the plan is actually posted, but being able to get some heads up on what may be in the plans or what are some changes or new things coming aboard. And so again, we'll have one more of these sessions tomorrow. There'll be some time for you to respond or provide feedback, and there's still, again, the formal 30-day public comment process that will also be going on, which will give people more opportunities, again, to comment and provide us with some feedback. With that said, I want to thank everyone who tuned in tonight. I want to thank our DBH team that is assisting us both here at the Hawk, but as well as our staff that are working remotely and monitoring the chats as well. So thank you all for your time. Thank you for listening. Thank you for your support, and good evening. Good night.